submit on Cougar Courses. Like there's no Dropbox where we can just drop the document in.
Oh.
So I'm not sure if you have to unlock it or something.
Okay, let me do this. Hypertension, and then I'll figure it out and open it for you right away. Okay.
Cool.
Okay. So blood pressure. This you know this already. This is the newer. It's not new anymore. It was new a little while ago, but the newer guidelines for blood pressure. So. The normal is now 80 to 120, whereas before 120 to like 129 or something like that was normal. And so the reason that they would have dropped this normal rate is because they're realizing that even at a moderate amount of pressure that the blood pressure causes on the vessel walls themselves is causing damage. Okay, also maybe causing damage to the kidneys at that higher rate as well, and all the organs that it goes to. So they actually have decreased the rate, and so pre-hypertension is now 120 to 139. Okay. There's different areas that help control our blood pressure within our body, and those are the arterial baroreceptors, so that's the sympathetic nervous system, and then of course our RAS system, our posterior pituitary and antidiuretic hormone also regulates, so that would be the antidiuretic ADH, aka vasopressin. And that is secreted when the blood pressure is low. So these all manage our blood pressure internally, and then natriuresis, which is our natural diuresis. And that is from the heart releasing atrial natriuretic, which is ANP and BNP, and that is in response to excess water. So this is what our body normally does to regulate our blood pressure. We don't need to do anything normally. The problem with hypertension is it shears the inside, the pressure shears the inside of the vessel wall. And then if we have atherosclerosis, that also then can weaken and stiffen the inner side of the wall, which then also allows the plaque to kind of be more impregnated into that media, intima media, and then it also will help push off any of those little clots, the hardening or the plaques on the outside, which then cause a rupture, which can then cause a platelet plug, and then we have a complete closure of the vessel wall. It can also damage the inside of the ventricle muscle, but what else it does as well is it increases the ventricle. So when there's more pressure going into that ventricle, it pushes out, causing the ventricle to be enlarged and the muscle to become weaker. So now we have a weak, damaged ventricle, okay, typically in this left ventricle. And that then in turn makes the heart work more, so it increases the workload. This in itself, because of the damaged muscle wall, can cause heart failure. This is one of the primary causes of heart failure. So we have two types of hypertension. We have essential, which is the most common, which the etiology for this is unknown. And it can be, some of the reasons that it could be would be some type of disorder that is making the RAS system be chronically stimulated. An increased blood volume can also cause this. That could be secondary from heart failure. It could be just from drinking too much fluids. Stress. So stress in itself causes angiotensin II to become elevated. And then, of course, vasoconstriction. So our secondary hypertension is something that is caused by a disorder that we are aware of. So secondary hypertension can be caused by kidney failure because we're not excreting that sodium and water. It's staying internal. Hormonal changes can cause it as well, such as hyperaldosterone. Our CHF can cause fluid overload, causing hypertension. Blood vessel changes, so our stenosis, atherosclerosis, narrowing the arteries and causing the blood to kind of rush through, causing an increase. If we have a decreased blood flow to the kidney for some, or any kind of obstruction or something to the kidneys, that the kidneys aren't getting perfused, maybe just because of an obstruction or damage to the kidneys, that activates the RAS system, which then increases the blood volume. And then, of course, medications. So as you can see, this is just a small list of very common causes of secondary hypertension. So sometimes if we can fix these causes, then we can decrease their hypertension without having to give them antihypertensive medications. Hypertension medications, we've already gone through these now, but let's just review quickly. We have our beta blockers, such as atenolol, and they reduce blood pressure, heart rate, and competes with the sympathetic nervous system. We have diuretics. We have loops. So we have hydrochlorothiazide. Hydrochlorothiazide is the first line of treatment for hypertension. And then we have loop diuretics and then potassium sparing. And they both decrease the volume, which in turn decreases the blood pressure. Remember that the direct-acting antihypertensive, so that which is a vasodilator, the hydralazine. Remember, I like this because this is a great alternative if someone has a low heart rate and can't be giving any medications that also decreases blood pressure. Our calcium channel blockers, these block that calcium. Remember, I call it Ativan for the heart because it decreases the tensity of what calcium causes. So it relaxes the heart, and it's also a vasodilator. We have our ACE inhibitors. There's numerous ones with the prils. They also cause vasodilation, as well as working on the angiotensin system. We have our central alpha medication. Remember, this is that strange one in the sympathetic nervous system that does the opposite for some reason, and that's clonidine. And then we have our ARBs, which also works on the aldosterone system, or losartan. This is a secondary line to ACE inhibitors. So ACE inhibitors are after hydralazine. So there's let me repeat that. There's diuretics and ACE inhibitors. These are the first lines of defense. Mild would be hydralazine by itself, and then if that doesn't work, they're going to add lisinopril. If for some reason you can't take lisinopril, then they would have the hydrochlorothiazide with the losartan. I showed you this before. This is the mean arterial pressure, or the MAP. Not too concerned about it in the regular med-surg floor, and really if it's just a cardiac patient, are we concerned about the MAP? However, in the ICU, this is what they use primarily because it does show us perfusion of organs. So it's a very important number, but it can be skewed slightly when you're not in the ICU. It's really for the ICU when or when things are going south with a patient, when we really need to check their perfusion.